So Scott has asked me to start with talking a bit about the milestones and key policy and service delivery achievements with respect to HIV, which is a rather huge area, and I know that many of you know lots and lots about HIV, but obviously ASHM's quite a broad a group of people now, and many of you of course don't work directly in the areas of HIV, but I guess overall the news is good in our response to HIV in Australia. Probably not good, it's excellent, but we shouldn't be complacent in what we are doing, and not only can we always do better, but if we stop doing what we're doing, things could dramatically change. So there is 27,000 people living with HIV currently. The numbers of new infections is declining for the first time in a decade, and the reasons for that are complex. I'll talk a little bit about that later on. Prevalence of HIV is about 7% in men who have sex with men, and about 1.4% in people who inject drugs. So the people most affected by HIV remain unchanged in this country, particularly men who have sex with men. But we're also very aware now that there are other populations that are at risk that need perhaps potentially different interventions. Some of the recent success stories in our journey in HIV, and I'm sort of really reflecting over the last 12 to 24 months, have been certainly in the areas of treatment and prevention. We're doing extremely well on reaching or almost have reached the 1990 targets, meaning 90% of people diagnosed with HIV, 90% of them on treatment, and 90% with a suppressed viral load. And at the moment, our targets we've reached 89, 95, and 86, which is pretty good. Many other countries have already reported 90, 90, 90, and we're pretty much there. The goals going forward are to get those rates even higher to 95, 95, 95, and that forms part of what's discussed in the national strategy. The other big advances in the last 12 to 24 months has to be in relation to PrEP, having this licensed on the Pharmaceutical Benefit Scheme in April of 2018 was a major achievement. One of the first countries in the world to provide free access, essentially free access to pre-exposure prophylaxis, and over 15,000 people taking PrEP, which I think is pretty extraordinary given Australia's population size. We've also got a lot to be proud of with continuing low prevalence of HIV in people who inject drugs, the virtual elimination of mother-to-child transmission, and very low prevalence or virtual elimination of HIV among sex workers. And again, they're things that we should remain proud of, but this doesn't happen in and of itself. It needs a lot of hard work and effort to maintain those numbers. Scott asked me to talk briefly about the new national strategies. As you know, they were announced and released late last year. The HIV strategy, I think, is a good one, mainly because it gives a very clear targets for what people should be working towards, and it also gives some actually, clear numbers of what we should be trying to achieve. And I think there are something like 33 action items there. I'm sure many of you will read those, but I think they're a very good template for us to develop work plans for over the next 5 years, or 3 years, I think, that the strategies are written for. There are a range of challenges, I think, in the HIV sector. I can talk a little bit about the medical challenges that I see going forward, and then some of the policy and structural challenges. So we still have a challenge in Australia of increasing and maintaining high levels of testing in all communities at risk for HIV. And although we are up around 89%, there are some communities in which these figures are far, far lower, particularly Indigenous communities. as well as certain MSM, particularly Asian-born MSM. And that needs to be certainly increased, and we need a really concerted effort around increasing testing. Prevention also poses a big challenge. How we roll out PrEP how effectively we roll out PrEP will be tested in the next 3 to 5 years. It's an incredible tool for prevention. As many of you know, if people take PrEP, you effectively eliminate HIV transmission or reduce it to 95 to 99%. And we need to make PrEP widely available to all communities at risk. And that means, as I'm sure ASHM has thought about a lot, educating a very different pool of people to the usual S100 prescribers. And so programs around skilling up GPs and communities and awareness of PrEP is so important. I've been really struck by the recent data on new infections in Australia, where we are seeing a reduction in new HIV infections if you're a Australian-born gay man living in inner Sydney. But if you're an Asian-born gay man, we're seeing those numbers plateau or even increase. Of course, we're also seeing alarming increases in notifications for new HIV in Indigenous populations. So targeted programs to access those communities will be really important. Increasing access and maintaining access to treatment also remains a challenge. We're doing that pretty well in Australia. The environment is very conducive to that with a fully funded public health system. But I think we can do better in initiating treatment earlier. The median CD4 count at which HIV is started in Australia remains high, but many people are now judging the time to start treatment from diagnosis to becoming aviremic and trying to really narrow that window with a test and treat strategy, which we haven't quite implemented yet all across Australia. We have to be really careful that the treatment, care and coordination that people might have living in inner urban Melbourne or Sydney looks very different to rural Western Australia or the remote Indigenous communities. So we need better ways to have equitable care no matter where you live in Australia. That's a struggle in all aspects of health, but particularly in HIV. What are some key innovations that might change in the next sort of 5 to 10 years? Well, I think we will see big changes in choices of testing. Home-based testing, for example, is now going to become more and more common. So different tests that we use for diagnosing HIV, I think, are also going to change, and we need to do a lot of work around that. Prevention options. At the moment we have Truvada, but there's a lot of work happening with long-acting antivirals, injectable antivirals, injectable long-acting antibodies, potentially depot delivery of antivirals, and all of those studies are happening now. And in fact, the first injectable formulation of cabotegravir or rilpivirine may well be licensed in 2019 for treatment. That's it. I was talking about prevention there, but treatment also will have access to many of those new innovations. The other big change in treatment, of course, is the fact that we may well be able to use 2 drugs rather than 3 drugs for many people, which is a great advance both in cost of medication but also potential toxicity. We have limited choice at the moment of what those 2 drugs might be, but I suspect that will expand. And I think the other big change in treatment that we're going to see is increasing integration of HIV care into mainstream services. There's a big debate that's been going on for a long time about whether HIV services should be integrated or individualised as separate HIV services. I don't think that's been resolved. It varies across the country, but I will imagine we're going to see a bigger shift towards integration, which is not always bad. The principles around complex care management are the same for HIV as for other chronic diseases. Finally, what might be the really big innovations with respect to people always asking about a cure and a vaccine. A lot of work still happening in those areas. I don't think they will be part of the treatment or prevention landscape still for a while. But ASHM also has for many years supported what is generally called Track A at their conferences, or basic science, and I think the strong voice for basic science from ASHM is really essential as well. Finally, I know that my time's up, but I wanted to put in a pitch for what ASHM should be thinking about in its international program. We can play such an important role regionally, as we have done, both in leadership programs, in twinning arrangements, in training, in the initiative ASHM had around linking regional societies. The landscape for HIV in our region looks very, very different. There's a lot of issues around human rights, a lot of issues around stigma, poor access to treatment in many countries, and some countries showing alarming increases. So I hope that remains very high on ASHM's agenda. I'll finish there. I hope your retreat is enjoyable, that you feel really inspired about all the work that needs to still be done in not only HIV but viral hepatitis and STIs, and I look forward to seeing you, if not before, at the annual ASHM meeting later this year. Thanks a lot.